Hello, everyone, and welcome to this Hoosier Extracorporeal Science Conference brought to you by Heartbeat Perfusion Solutions, which is a national provider of specialized perfusion and extracorporeal membrane oxygenation services, also known as ECMO. I will be your host today. My name is Sam, and I am joined by Dr. Faten, who is a highly respected critical care consultant at the National Heart Institute in Cairo, Egypt. With over 15 years of experience in cardiac critical care, she holds a Bachelor of Medicine and General Surgery, a master's degree, and a PhD in intensive care medicine, which is the highest qualification in the field in Egypt. She's also served at King Abdullah Medical City in Saudi Arabia and is the founder of Faten Critical Care YouTube channel, which is a leading resource dedicated to education in cardiac surgery, ICU care. Welcome, Dr. Faten. Thank you so much for joining us today.
Thanks for introducing me. I'm glad to be part of this event. I wish my presentation will be very simple and a quick presentation for intra-aortic balloon counter pulsation. I tried to make it very simple, no more complicated things. So I will start first with, I have no disclosure related to this presentation. My outlines will be a quick revision of physiology of intra-aortic balloon pump. I will try to put quick interpretation of the intra-aortic balloon pump waveform, and I will give a quick summary for troubleshooting and how to do troubleshooting with schematic approach. To be in a schematic approach. First of all, intra-aortic balloon pump counter pulsation means there is pulse, and the counter pulsation referred to the balloon inflated during diastole and deflated during systole. And this is very important for the action of intra-aortic balloon pump. And to be known that intra-aortic balloon, to do the work or affect the patient, we should have at least stroke volumes 33 or cardiac index 1.5 and not less. So to have a counter pulsation, we should have a pulse. Then what the effect of intra-aortic balloon pump? Intra-aortic balloon pump can have, regarding the demand, it will decrease the demand, and it will decrease the demand, and regarding decrease the afterload and decrease myocardial oxygen intake. And during inflation, so there will be increase or volume displacement, so it will increase coronary supply, which occurring during diastole, and increase systemic perfusion. Then if we go for the next slide, this is the shape of the console of intra-aortic balloon pump. The shape means this is the first ECG, which is the source of trigger. The second is our arterial pressure waveform, and this is the balloon inflation and deflation. This is the balloon is inflated or not deflated is appear on the curve, and this is the source of helium, which inflate the balloon, the gas which inflate the balloon. Then, very important thing to decide if we have troubleshooting or not is the trigger. What I mean by trigger? Trigger is the balloon and the interaction between the balloon and the console of the interaction between the patient and the console of the balloon. So what's mean by that? It's physiological signal telling the console if the cycle will start or the cycle will end. So it should be organized. If the balloon will inflate it or the balloon deflated, all that will reflect it to our patient, increase the physiology of the balloon itself. So what the source of the trigger? Maybe ECG, arterial pressure waveform, or pacemaker spike if the patient is dependent on pacemaker and we can't adjust the ECG filters or something like that, so we will put pacemaker spike. To understand the balloon troubleshooting, we should understand what meant by arterial pressure waveform. This is arterial pressure waveform representing one cycle. The one cycle is systole and the diastole. This is dicrotic notch, which representing the closure of mitral closure of aortic valve, and this very important sign for or mark for the troubleshooting in the intra-aortic balloon pressure arterial pressure waveform. If we wanted to interpret the waveform, we should have first, we can't interpret the waveform while we are in frequency 1-to-1. We should make it 1-to-2. In some centers, they can print a strip. In my center, we can't. So we should have 3 tops and 3 downs. So that's very important to put in our mind. Now we have 1-to-1. What we can explain first what each one is mean. This is one cycle, cardiac cycle. This is systole and this is diastole. First, this assisted systole, and this is diastolic augmentation, and this is assisted end diastolic pressure. Can we predict any troubleshooting in this curve? No, we can't. So we should go for 1-to-2 to understand where are we. This is a normal curve for intra-aortic balloon pump. The frequency of this curve is 1-to-2. This is so if we go to this unassisted systole, this is diastolic augmentation, assisted systole, and end diastolic end assisted end diastolic pressure, and this unassisted end diastolic pressure. Let us stand a little bit with this curve. Intra-aortic balloon to work, it will decrease, and we can see the systole, the assisted systole will be slightly lower than unassisted systole, but the diastolic augmentation or diastolic pressure will be more than the normal diastole, and the reflection will be on the map. The map will be higher than normal. So if we have a problem regarding the timing, early inflation, like you open air bag in the while you are driving, so the bag will come to your face, and this means that the balloon opened while the aortic valve is open, so will be 2 forces against each other. Timing error for early inflation, that's mean early inflation of the balloon should, proper inflation of the balloon should be immediately above the dicrotic notch. Here we will see it's more earlier than dicrotic notch. So still the aortic valve not closed. So it will cause our aortic valve close premature, increase all diameters of pressures of the left ventricle and diastolic pressure, left ventricle and diastolic volume, increase pulmonary capillary wedge pressure, also increasing afterload, which against the function of the balloon to decrease the afterload, and also we cause aortic regurgitation when the bag come in the face of the man in the previous picture. The coffee is thrown on his. So this is the same. The aortic, the blood regurge again, come back to the aorta. Then late inflation, that this is the dicrotic notch here. So it will inflate after the dicrotic notch. So we will not have suboptimal augmentation. We will not have suboptimal coronary perfusion, and there is we will not have the good function of the balloon. In the second part, early deflation, we see in the normal physiology of the curves, unassisted end diastolic pressure should be higher than assisted end diastolic pressure. You'll see here. So we will find in early deflation that there is no the unassisted diastolic will be the same, so no benefit from the intra-aortic balloon pump. So there will be suboptimal coronary perfusion, retrograde coronary and carotid flow, and suboptimal afterload reduction, and increase myocardial oxygen demand. And the late deflation, we will find that there will be after load reduction will be absent, and increased myocardial oxygen consumption, prolongation isovolumetric contraction, and late ventricular ejection will be abnormality. So let us to interpret this in a real case. We have 72 years old man. These have severe cerebral vessels, coronary artery disease, congestive heart failure, ejection fraction is about 25%, and type 2 diabetes. He went for operation, CABG by time 3, and the patient has LIMA to LAD and vein to OM and RCA. After that 6-hour post-op, the patient has decreased augmentation on the arterial waveform. The console giving time error, showing time error. Mean arterial blood pressure dropped from 75 to 60 millimeter mercury. The patient started to be oliguric and mottled. The vital signs showing that heart rate is 94. He is 94 sinus rhythm, and blood pressure 85/50, MAP 60. Central venous pressure is 10. Arterial waveform showing poor augmentation and inflation mismatched. So this is the shape of the malformation. Here we can see the arterial wave show early inflation, and we took an X-ray for this patient. We find the balloon up in not in the normal position, should be at the level of second intercostal space, or to be honestly 1 centimeter from the carina. Sure, we adjusted the. How can we go for step by step to see how can we interpret or assess the anti-aortic balloon? Initially check balloon inflation and deflation. It's not synchronized with ECG form. Inflation occurred too early, prior to the necrotic notch. There is no alarm for gas or helium exchange. So the error can be inappropriate inflation. There is reduction in perfusion and reduction in coronary perfusion, increase in myocardial oxygen demand, and also there is affection of cardiac output, so that lead to mottling and decrease urinary output. Then, so I will put assessment step by step. It starts from trigger source, then go for clinical assessment. The first thing, confirm a trigger source. Is this ECG is important. It's current trigger ECG, stable, sinus rhythm. Okay, it's okay. Then go, if not, ECG is not good, the patient atrial fibrillation, or we don't have clear source, there is noise in ECG, sometimes happen with patient on pacemaker, please switch to arterial pressure trigger. Then reassess the timing, using arterial pressure waveform and ECG to guide that. Inflation should be occur at dichrotic notch. Deflation should just be for R wave at the start of systole. Manually adjust timing using the time control in the console. If we can do it by auto mode in the console. Third thing, assess balloon function. We should check the console for helium gas pressure and battery function. Inspect tubing for kinking and disconnection. Clinical monitoring. After all of that, if we go step by step, we manage the early inflation. We manage every step. There is no helium problem. There is no kinking, nothing. We should, after that, go for clinical monitoring post troubleshooting. Is the blood pressure is augmented? MAB is okay, urine output, lactate, and also we should check EBG and mixed venous oxygen saturation if needed. And after adjusting this, adjusting the balloon, this is proper inflation. The balloon is, we will see the inflation here, the half of the wave, and immediately parallel to the necrotic notch. And my lecture's end. I wish to receive the questions, and thanks for everyone.
Thank you so much for your presentation. I now have some questions from our community, as well as some of our team on your topics that we'd love to go a little bit deeper on with you. But firstly, do you need a sip of water or anything? I know that was a lot to go through a presentation like that, so thank you.
Okay, we can start.
Okay. So the first question I have for you is, what are the signs of late inflation on the arterial waveform, and what does that indicate about your timing settings?
Late inflation on the arterial blood pressure waveform, you will see the necrotic notch appear clearly in front of you, and this is in the monitor. Besides, we will have abnormality regarding patient hemodynamics and abnormal malposition. We should, as I told you before, we should go step by step. I don't like to go immediately for the troubleshooting. Before we have late inflation, so we have reflected on the patient dynamics, patient clinical status. So we'll first go confirming the trigger source, then assess the balloon function, and after adjusting each point, we should check for another presence of any problem regarding the another alarms, helium, kinking in the balloon, obstruction. Then we will go for post troubleshooting monitoring.
Okay. And in the event the patient does become hypotensive despite IABP support, what are your differential diagnoses and what next steps would you take then?
Excellent question, and very common. We have these questions while we are in, especially post-cardiac surgery. The patient may be hypovolemic, patient may be in sepsis, patient may be RV failure, and as we know, intra-aortic balloon didn't support the right side failure. The patient may be in severe LV failure. That's mean to support, as I said in my presentation, to support the heart with a balloon, we should have a pulse. We have at least cardiac index 1.5. Less than 1.5, you will not have good augmentation from the balloon, as the balloon only provide 15% for cardiac output, about 0.5 liter per minute. So maybe this patient has to escalate more to ECMO, for example, Impella, the balloon not good option for him. Or even have mechanical obstruction, like LV rupture, something like that.
Mm-hmm. What if the IABP catheter becomes kinked or occluded? What steps would you take at that stage?
As I said, we will go step by step. First, we will check the trigger source. It's okay. We will check the balloon. If you find kinking or obstruction, we will deal. See if there is blood in the catheter. If there is kinking inside, from the side, maybe it's just kinking from the side of fixation. You can take off the stitch. If you find there is everything is okay from your side, you can see if the patient is stable or not stable. It would make a difference. If the patient is stable, so we can go to take it off and end of the if just the problem is helium rupture of the balloon or something like that, blood in the, so take it off. If the patient not stable, so we can think after echo, doing echo and assess the patient well. If he need more to escalate more or for VA ECMO or something, or we can take off the balloon and insert another one. But we should, this is transitional stage. We prepare us with inotropic support and pharmacological drugs.
Okay, thank you. What about if the IABP fails to trigger on the ECG? Are there adjustments that we can make on the console in that case?
We should first check the ECG and to try to avoid any noise and try to fix it again. If there is failed completely, we go for intra-aortic balloon pressure waveform. Especially nowadays, the recent machines have fiber optic and it's very excellent for triggering. This is very common scenario if the patient is in pacemaker. So intra-aortic balloon have pacemaker mode for trigger, and it's better to use pacemaker mode for triggering.
That was a question I had is what adjustments are needed if the patient is being paced or has a pacemaker in place?
Pacemaker in place, just clear ECG connection. It's I never faced this problem with the pacemaker mode. It's excellent.
Okay.
I face it when I patient has pacemaker and I use ECG only.
Okay. And does the IABP function differ in patients depending on whether they have right ventricular failure compared to left?
We didn't. There is a clinical trial was released recently,
Okay.
and in my center, they use it in two cases in RV failure. It said because it will increase the coronary perfusion in right side. It doesn't make difference, and in my opinion, the patient become more worse, and we go for ECMO better.
Okay.
Uh,
Okay.
for
And
me,
the
I
last,
didn't advise. For me, I
okay.
didn't advise it in right side. It did not provide any support.
Okay, the last question that I have for the community, thank you so much. You've answered so much from us. Is what are the steps that you would take if the patient develops decreased pulses or coolness in the limb distal or in the IBP insertion site?
This is excellent question. We first of all, since we insert the intra-aortic balloon, we shouldn't every day do assessment and never let this stage to come. We can use anticoagulation, and check it regularly. But if it's happened, we will check the clinical status of the patient. If our patient is stable and we can get out the balloon quickly and get it rid of it, okay. If we can't, we can go to insert another one in the another side and see if we can if it's okay to insert the another side. Besides calling for vascular and involving them, sometimes just decrease the pulse, just need to warming the leg and just warming and increasing the anticoagulation target BTC. This is will help to save the limb.
Okay, thank you. That's all the time that we have for today. You've been so generous with your knowledge. We really appreciate it. We'll be sure to include links to all of your amazing work, including your YouTube channel in the links below. And for everyone who has tuned in, this conference is brought to all of us by Heartbeat Perfusion Solutions, a national provider of specialized perfusion and extracorporeal membrane oxygenation services. You can learn more at their website, heartbeatperfusion.com. And we have more amazing speakers like Dr. Faten as part of this conference. We encourage you to watch all of those videos and reach out to them directly if you have any questions. Thank you so much. Bye.
Thanks.